Hi everyone, welcome to the TBPPM Features section of the TBPPM Learning Network. In this section, we will be highlighting innovative projects and interesting practices that are prevalent in the field of tuberculosis. Joining us today is Ms. Rosa Pep, the Research and Monitoring Evaluation Lead for USAID-funded SHOPS Plus um, project and an associate with ABT Associates. She will be sharing with us about how SHOPS Plus adapted the mystery client approach to assess the quality of TB care provided by their network in network of private providers in Nigeria. So thank you so much for joining us today. Could you give us a brief overview of this initiative?
Sure. So since 2018, we've been implementing a PPM model in Lagos and Kano under the USAID-funded SHOPS Plus project. And under that project, we've been trying to set up and implement TB testing, identification testing and treatment networks of private providers who operate in urban Lagos and Kano metropolitan city. And so those networks are actually multi-cadre networks. So they are consisting of clinical providers, they're consisting of standalone private laboratories, community pharmacists, and then also drug retailers that are known in Nigeria as PPMVs, or patent and proprietary medicine vendors. So it's sort of kind of your low-level community drug sellers all the way up to your clinical providers. And the reason that we have these multi-cadre networks is that in Nigeria, a lot of people use PPMVs as their kind of first source of healthcare. And because of that, we wanted to equip them to be able to identify potential presumptive TB patients, and then be able to both collect a sputum sample from them to be able to increase TB diagnosis, but then also refer them to a place where they could get TB care. So this is all in the service of addressing the gap that Nigeria has in what they estimate as the TB caseload and like what the actual notified caseload is. And we think that a lot of people are falling through the cracks because they use the private sector as their source of healthcare. And, there have been some efforts to engage the private sector before in TB service delivery, but they'd sort of been small, or they hadn't been as expansive as ours. So we tried to really think about how people use the private sector when we were setting up our networks, and then make sure that all of those different cadres were sort of equipped to play a role in increasing TB detection and treatment. So that was the initiative itself. And then as we were setting up our networks, USAID, who had been quite familiar with the work that the McGill International TB Center had done in India, had asked us to think about doing a mystery client or an SP study, standardized patient study, with our network providers, because I think they were very keen to try to both maybe initially skeptical about like what the quality of care a PPMV could provide, but then also just wanting to give us, have us be able to use an innovative practice to understand what the providers in our networks were doing when they encounter somebody that presents with symptoms that are consistent with presumptive TB, or when somebody shows up that actually has confirmed TB.
Okay. So what were some interesting findings that came out of this study, Lauren?
Yeah, so I mean, I think there are a lot of interesting findings. I think overall, as others that are affiliated with the McGill Center have found in their similar studies, the overall level of quality when it comes to kind of screening and moving presumptive patients toward diagnosis and then eventually treatment is that the level of quality is fairly low, which we weren't entirely surprised about, just because of the other global studies that have been done. And so I guess we were, a little bit disappointed that it wasn't, that we weren't finding anything drastically different. But I think some of the interesting things we found were that unlike some of the studies that I think have been done in other contexts, screening went relatively well amongst our network providers. So they know how to screen, and that in fact had been something that as a program we had emphasized quite heavily, was, screening people, making sure that, if somebody comes in with a cough, that you're asking them about if they've experienced other TB symptoms. And we found that when our presumptive standardized patients presented with really basic textbook symptoms, that screening was overall a fairly high percentage of providers engaged in that. However, when things kind of fell off the rails a little bit was with the next stage, which we had wanted them to take an effort to get a sputum sample, or recommend that the standardized patient go somewhere where they could be tested and provide a sputum sample. And that's proved to be a bottleneck for some of the providers. And I can talk a little bit about like why we think that is. But I think that was one thing that's been interesting and actionable for us to just know, like, that's where providers are getting a little tripped up. We also found that providers, especially more at the lower levels, so like the community pharmacy or the PPMV level, were not necessarily dispensing TB drugs, which would have been completely not appropriate for somebody that's not diagnosed with TB, but still providing like fairly high, in a fairly high percentage of cases, dispensing antibiotics. So, kind of your run-of-the-mill antibiotic. And we want to see less of that, just because that fuels antibiotic resistance. So, and that's something that we've seen in other studies as well, that there's quite a bit of that. So I think that was some of the interesting things we found on the presumptive case side. We also looked at what happened in clinical settings when a confirmed TB patient comes in with, maybe they've, especially in our networks, the way that it works is that a patient can be diagnosed outside of a clinical setting. So for instance, they may go to a PPMV or community pharmacy and be, asked for a sputum sample, and it's the PPMV or the pharmacist that actually sends that sample out to be tested. And then they are the ones that get the test results back. So what happens is once those test results come back, and if they're positive, they will contact the presumptive patient and say, hey, I've got your test results back. Let's talk about them. And then ideally the PPMV or the pharmacist will then say, here are some places you can go, which include public sector facilities or private sector facilities. But what happens is they'll send the patients with their gene expert results to a clinical facility. So we wanted to see both that, like, somebody coming in to a clinical facility with a gene expert result that had been, diagnosed in the community, how clinical providers would sort of react and then walk the patient through treatment initiation, counseling, and all of that. And I think some of the interesting things we found that in public facilities that we engaged with, some of the public providers were very confused about how it would be possible for somebody to be diagnosed in the community, which to us helped us understand that there wasn't maybe enough awareness in the public sector that we have a PPM model running in Lagos and Kano. So that was something that was actionable to just sort of say, we need to increase the awareness of this so that providers everywhere, whether they're in the public or the private sector, are ready to respond. But then another thing that we found once we got to the counseling piece of the initiation was that providers are, and this is actually not all that surprising, but providers didn't go into enough detail in their counseling. So some of the things that they provided maybe less detail on is, reemphasizing that TB is curable, which is important for lessening stigma, encouraging the identification of a treatment supporter, or even bringing up like DOTS protocols. So some of that to us suggests that maybe providers need a little bit more coaching about how to engage with newly diagnosed clients. I mean, I think the ultimate goal, which they tended to do well in our study, was move the patient toward treatment. So either setting up a plan for them to pick up their drugs or giving them physically drugs to go and take, which in our study they weren't allowed to take. So we had to get them to come up with an excuse of why they weren't able to ingest the drugs at the moment. But we wanted the providers, so the providers were moving the patients toward treatment, which is good. But on the flip side, by not providing enough counseling, you're missing opportunities to promote adherence. You're missing opportunities to really have a conversation that makes care a little bit more patient-centered. So having the patient have an opportunity to ask questions, learn a little bit more about what they've just been diagnosed with, because I think TB is so stigmatized, there's a good opportunity to really address some of those things. So, so I think our counseling scenario that we tested in our survey really showed that there's a lot of opportunity. But I think another interesting thing in both of the scenarios that we tested was that we looked at our SHOPS Plus networks performance and the public sector performance. And the goal of our study was never to sort of say like one side can do better than the other, but we wanted to understand, like, can our networks provide a level of care that's sort of consistent with the status quo of TB care? And in comparing the results from our studies between the two sectors, we find that the PPM network providers and the SHOPS Plus networks were able to really achieve the same level of quality as we were able to observe in the public sector. So even though everybody's sort of generally low, and so there's room to improve across the board, I think the good news is that we've been able to see that we can have a truly public-private mix model and achieve sort of a comparable level wherever you go, which I think makes it a little bit easier, because then you can sort of address issues in a more blanket form rather than saying, well, things are a lot worse in the private sector, so we need to do X, Y, Z. I think we found that things were a little bit more consistent. So I think that was good news for us, because it is still, we've been implementing since 2018, but which isn't a whole lot of time, but I think it's good news that we've been able to set up like functional networks that are really driving in a lot of cases, which is great.
Great. Okay. So, what were some major challenges that you faced while conducting this study?
Yeah. So, mystery client or standardized patient studies are actually quite difficult to pull off. We worked really closely with a member of the International TB Center Consortium. Her name is Ada Kwan, and she helped us very much in understanding just how hard these studies are to pull off. Because I think if anybody else is familiar with the mystery client approach, oftentimes it's like you're sending somebody in to buy something, or where we've used them before, they're going in to have a fairly simple transaction where it's like we've used mystery clients to sort of test out whether they're getting ORS and zinc from PPMVs, for instance. But that's pretty simple, because you're just pretty much going in, asking for medicine and seeing if you get it. In this case, though, we had to make sure that all of our data collectors came across as very convincing TB patients, either somebody that had TB or somebody that had symptoms of TB. We had to make sure that our standardized patients were ready to be examined and be able to answer all the questions that a provider might ask you about your background, your family, who else you live with. And so it really just ups the level of detail and the level of training and preparation you need to have somebody be truly convincing, to be able to really accurately say, like, well, here's how we think these providers are interacting with actual patients. So that takes, to get somebody to the level where they can be truly convincing and not be able to be detectable, is like over 100 hours of training for us. I think it was a total of 100, and I think if we're clocking it exactly 144 hours of training it can go up to be even more. So that's a huge investment of time on everybody's side. And then I think another thing that's challenging, or was a little surprising to me, I think going into this, is so much work has been done by like Madhu Pai and Ada and other teammates to really think about using standardized patients for examining TB care quality, that we thought, okay, well, they have all these tools. It'll just be a matter of us kind of applying the tools in the Nigerian context. But we had to do quite a bit of customization to the Nigerian context. I think even our client was quite surprised about this, because that's the reason I think they asked us to do this in the first place, because they thought it'd be pretty easy since McGill's put so much work into designing the tools. But then we had to do quite a bit of additional work to just contextualize them to what makes sense in urban Lagos and urban Kano, which are in and of themselves two really different places. So we had to think about, how might somebody say or describe their symptoms? What name might somebody give? What name might somebody give in Kano? We had to think about some linguistic differences. So if you give a certain name in Lagos or in Kano that's associated with a certain ethnic group, you have to be sure that that person that you're giving that sort of fake name to can actually speak the relevant language. So we had to think really, really carefully about all the details. So I'd say that's the most challenging thing, is just to prepare the cases so that they're convincing, and then prepare the mystery clients or the standardized patients so that they are convincing themselves. So it is a lot of work.
Okay. And finally, like, how did the program staff react to the results that you showed them?
Yeah, I mean, I think there are actually some things that they were not so surprised about. So I had talked about earlier that a bottleneck that we found when we were looking at kind of presumptive patient care quality was that we weren't seeing providers necessarily collect a sputum sample or recommend that the standardized patient go somewhere else for sputum sample collection. And one of the things that happened kind of concurrently to our study design or study implementation was there were some fairly serious problems going on with the national gene expert system. So most gene expert machines in Nigeria are in the public sector. So what we end up doing is transporting sputum samples from private facilities to public gene expert labs. And at the time, a lot of those labs are really struggling because of just typical issues you might see in a developing country context, where they might go offline for a little bit because the generator went out and there's no electricity, or the machines have broken. And the thing with gene expert machines is that they are proprietary and they require like specific technicians to come and fix. So when they go down, it takes time to fix them. And then they also require these little special cartridges to actually run the tests. And at the time, or right before we started implementing, there was a national cartridge outage for gene expert machines. And that caused huge backlogs across the country, not even just in Lagos and Kano. And that created some big issues downstream when you're trying to test people and move them toward diagnosis and treatment, when you have to wait 3 weeks, a month, maybe even more for a test result. And at the time, a lot of our providers were expressing quite a bit of frustration with that system. And so what we think may have happened is that, kind of as a result of all the issues that we had faced earlier, that like before we started implementing our study, we think that probably some providers grew skeptical of sort of almost the utility of doing a sputum sample, because what they were telling us was that it could create some ill will between a provider and their customers. So like, if you're saying, well, let me take a cough test from you, and then you never come back with the results, or I come back with the results so late, they were complaining that this made things difficult for them and their clients, which is understandable. So I think it wasn't, because of all those issues, it wasn't very entirely surprising that that could have been a bottleneck for the providers. So our program took a lot of efforts since we kind of saw those study results and since we knew about the issues to begin with, to try to address some of the bottlenecks we were seeing. So come up with alternate ways to sort of move sputum samples to more functional labs where there wasn't as many backlogs, or trying to work with the national TB program to sort of say, well, if we are seeing a lot of backlogs, can we substitute with AFB testing? Because we have all these labs in our network that just use AFB testing. So I think we were able to kind of use the study results to sort of say, like, as an extra boost to say, like, we have a problem, we need to do something about it. So that was one thing where they were like, oh, not surprising, but like helps us do what we need to do. And then I think there was a little bit of, I think, again, not total surprise, because we know in general that providers, especially, well, I think providers in any sector, but sometimes in the private sector, we see that there's some challenges with spending time doing counseling because there's pressure to sort of see as many clients as you can. In the public sector, not quite the same pressure, but you might have a huge client load and not be able to spend time counseling. So on either side, there are also disincentives to counseling. So I think the fact that we didn't see providers going in depth as much as we had is really what the guidelines expect that they do. It was not entirely like earth-shatteringly surprising, but having that the survey result helped us get more insight into what they weren't going into as much detail about, and whether, those things were super important or not. And so we used the test results, or not the test results, the survey results, to design a job aid for the clinical providers that are in our network. So to help them kind of reference when they are counseling, what are the different things they need to go through? Because there are so many different things you need to cover. And again, they are rightfully so concerned about getting the patient on treatment, but we also want them to spend a little bit of time on counseling. So we've designed this job aid, and in the next round of the survey, we'll see if we see any improvement, hopefully use of the job aid in the actual session itself. And let's see, what was I going to say? There was one more thing, but I think I've lost my train of thought. So
okay, no worry about it. I just wanted to know about the COVID situation. How has it impacted the project and the study?
Yeah, no, that's a great question. So I think Nigeria has been very lucky in the sense that they've dealt with some pretty serious disease outbreaks in the last few years. So most recently, before COVID, was Ebola. But Nigeria did very well in sort of responding to it. So they had, I guess, a little bit of practice. And although they, like everybody else around the world, experienced shutdowns and a lot of disruption basically around April, and then maybe a little bit into May, they were able to get quite good control over the spread of COVID in the country. They've had there has been more concentrated outbreak in Kano, but they've gotten a little bit of a better control over it. But on the whole, the sense across the country is that things are relatively in control. People have kind of adjusted to wearing masks, as we have in most places around the world, maybe not everywhere in the US. But so there were some shutdowns, there were a little bit of drop off in cases, but we've actually seen things bounce back quite a bit. Like, in fact, it's back to normal levels. And in some, what we heard is that life is essentially back to normal. Now, we don't know this for sure. And we are now actually part of a global study with Dr. Pai and the McGill TB Center to look at what has happened with private sector TB service providers as a result of COVID. So we have our mystery client data, we have our program data that reflects the time before COVID, and we're working with Dr. Pai and his team to plan additional data collection now and then into next year to really sort of explore this idea of like, well, how has the practice of TB service provision changed since COVID has been on the scene? So I don't know for sure. I think like compared to other places, Nigeria seems to have weathered the storm quite well, although we'll see. Hopefully knock on wood for everybody's sake that it continues to be the case there. But we won't really know for sure until we have data from our study to kind of answer that question.
Okay, great. Thank you so much for answering that. And what advice would you give for a learning network who would want to do similar kind of studies in their region?
Yeah, I mean, I think like I was describing earlier, standardized patient studies for TB are not a light undertaking. So it takes quite a bit of resources. They're not cheap to do because you really need to, basically because the training is so intensive. Like sometimes with surveys, you can do a training in a couple days or a couple weeks, and this really took a lot longer. I think even though there are so many great resources that we heavily relied on to pull off this study that have largely been generated by the McGill team, I think you can't expect to just use those tools without thinking about your own context and like doing quite a bit of adjustment to your local conditions, and also just local interests and like what types of providers you work with. And so I think it takes, whereas I think our client originally thought like we could largely just like plug and play the tools, it took a lot more to really get them to be workable in the Nigerian context. And I think that would be the same in any context. So I think this is something to account for. And then I think it's just, it's a type of study that lends itself to being extremely detail oriented. So thinking through every single detail that could possibly be needed. So everything down from like, do we change so one thing that we struggled with a little bit that we adjusted to was thinking about what kind of name somebody brings or what name they give when they're being checked in at a facility. I think in some cases we had somebody just use the same name and they might have gone to several facilities, but you had to think about, well, how good is the data collection system behind those facilities? Is it a unified data collection system? Is it something where people are paying a lot of attention? So in a case where like facilities are operating really independently of one another, you could use the same name, have the same standardized patient, go from facility to facility and give the same name. But if you have somebody that is tracking data really closely between facilities and they're on top of it, they're going to notice, there's this person that keeps going from facility to facility, which happened to us when we were piloting. So we had to think about ways to sort of, luckily it was like our own program staff that noticed this. It wasn't the facility themselves, so it didn't have an impact on how the providers were interacting. But we had to think, but like, I think that's something, if you're doing this kind of study, you have to think about everything that's happening and how all the different ways that you could possibly be detected. And then all the possible ways that your mystery client could be asked to do something kind of crazy. So as mystery clients, we also had to train them to be really good at giving excuses to avoid invasive procedures, because they're just like doing their jobs. They're not actually TB presumptive patients are actually confirmed TB patients. So we don't want them to be taking any TB medicines. We don't want them to be subject to injections. So we had to think about, and we worked with Ada to think about ways that excuses that have worked in other contexts to avoid these procedures. And they largely worked, but we had to like innovate a little bit to kind of think of things that were workable in kind of a local context. So I think it's just, to do it is definitely like it's a very difficult study to pull off. Not because it's like complex in like the analytical work that you can do later, but it's more just like getting somebody to be a convincing person and then make sure that they like really melt into the rest of the environment is actually very, very difficult. So I think if you're ready to take that on, like you just need the resources and the time and the patience and the attention to detail that it takes. If it's something where you need more immediate and more readily available data, then I would recommend maybe thinking about a different approach, because there are different approaches to understanding quality. There's like pros and cons. So obviously, like a client exit survey, you may deal with sort of recall bias. A provider survey, you're going to get provider bias. So and for mystery client, one of the things that's great is that you can like sift out both recall bias and the provider bias a little bit, but because it's so hard to actually pull off, that's another downside. So I think it's just thinking about what kind of downsides you can afford to take on, and then kind of roll from there.
Okay. Thank you. Those were great suggestions, Lauren. Thank you so much for all these great suggestions. Thank you for sharing your experience with us.